Hello, I'm Myra Kelly. In the United States, more than 11 million people have been diagnosed with COPD. As of 2013, the American Lung Association estimates as many as 24 million people may have the disease without even knowing it. As of May 2011, the CDC suggests about 25 million people have asthma. Cigarette smoking is the most important risk factor for COPD and asthma. Cigarette smoking has accounted for 480,000 deaths every year. The CDC suggests nearly 1 in 6 American adults currently smoke. A number of therapies have been developed to aid in the cessation of cigarette smoking. Among FDA-approved therapies are Chantix, Zyban, and nicotine replacement therapy, such as skin patches, gums, sprays, inhalers, and lozenges. Another resourceful tool in smoking cessation is behavioral support, such as counseling. There are different types of behavioral support. The types of support are face-to-face meetings, telephone support, online programs, and Nicotine Anonymous. The purpose of this presentation is to focus the discussion on smoking cessation among individuals with COPD and asthma, using a combination of pharmacotherapy and behavioral support for improved success of smoking cessation in about a 6-month time frame. Multiple studies have been conducted to support the improved outcomes for utilizing a combination of both pharmacotherapy and behavioral support. To validate research study findings, a hierarchy of evidence must be reached to determine that data used meets the rigorous requirements to support the aim of the study in professional practice. Randomized control trials meet these requirements for supportive evidence. For supportive evidence regarding smoking cessation among individuals with COPD and asthma, used in both pharmacotherapy and behavioral intervention, I utilized 3 randomized control trials found using the databases CINAHL and PubMed. The first randomized control trial, written by Liu et al. 2013, titled Supporting Smoking Cessation in COPD with Behavioral Intervention, a randomized control trial. This article supported evidence of using combined therapies. 46.4% showed improved smoking cessation versus only about 3.4% in a control group who received care as usual. Study number 2 by Selby et al. 2014, titled A Pragmatic Randomized Controlled Study Evaluating the Access to Smoking Cessation Through Pharmacotherapy Coverage, supported that 20.8% of study participants who had prescription coverage continued abstinence at 26 weeks, using both pharmacotherapy and behavioral support, versus only 13.9% of participants who did not have prescription coverage. And finally, study number 3 by Tashkin et al. 2011, titled Effects of Chantix on Smoking Cessation in Patients with Mild to Moderate COPD. This study revealed that 42.3% of smoking cessation among subjects who received pharmacotherapy and behavioral support versus 8.8% of smoking cessation among subjects in the control group, which was the placebo drug and behavioral support. Each of these studies supported an increase of effectiveness on smoking cessation when both therapies were combined in the target population. To bring evidence-based interventions into the clinical setting, a clear clinical algorithm can be an effective tool to achieve an improved outcome for the aggregate population. I propose an intervention algorithm that can be collaboratively tailored between both the practitioner and the patient that includes both evidence-based therapies. This proposed algorithm can be viewed on the companion PowerPoint presentation. If the proposed algorithm was utilized in practice, the target population could be identified, screened, and presented with treatment options for successful intervention that produces a healthier patient outcomes. I hope that you have enjoyed this presentation and have gained useful knowledge regarding the future practice in the clinic setting. Thank you.